Sounds great.
Welcome, everyone. My name is Karen Lee, and I would like to welcome you to the California Improvement Network, or CIN, webinar, Accountable Care Organizations, What's Next? Challenges and Opportunities for Primary Care. Just a quick word about the CIN. It's a partnership between the California Healthcare Foundation and 8 partner organizations to support spreading improvements in chronic disease care. We host these monthly webinars on timely topics related to improving chronic disease care. Since there are a number of people joining the webinar, everyone has been muted upon entry. And if you would like to ask a question, please raise your hand. There's a, mid-screen, kind of on the right-hand side, there's a button that you can click on that says Raise Hand, and if you do so, I will unmute your line. And you can ask a question either during the presentation or we've reserved the latter 20 minutes for Q&A for the presentation. Or you can send me questions through the chat function. That's kind of at the lower right-hand side of your screen. I'm delighted to introduce our speaker today, Dr. Wells Shoemaker. Dr. Shoemaker is the Medical Director for the California Association of Physician Groups, or CAPG. He also serves as co-chair of the California Quality Collaborative, a statewide collaborative of major purchasers, major health plans, and CAPG. And prior to joining CAPG, Dr. Shoemaker was the Medical Director for the Regional Medi-Cal Managed Care Plan in the Central Coast, Medical Director of an IPA in Santa Cruz County, and practiced primary care pediatrics for 25 years. So without further ado, I will turn it over to Dr. Shoemaker.
Thanks, Karen, and thank you all for sacrificing a peaceful, relaxing lunchtime to join us and talk about something that I hope will be exciting. I think as we go through the slides, one of the questions that's going to be in the back of many minds is the ACO concept, which is rather new on the scene, another example of the latest, greatest thing, and a fad destined to go the way of community health information networks and so many others, or is this going to stick, and is this going to make a difference? And I'm not going to suggest that I have the answer for that, but what we'll try to do is talk about the best grip that we have on it now and what that means, and I think have a particular focus on what this means for primary care. And we'll be emphasizing not only the what's in it for me for primary care, but what's in it for me from society's standpoint with supporting primary care as the economical quality engine for overall health care. So I'm going to be asking Karen to shift slides. I'm out in the Inland Empire remotely, and let me just do a sound check first. Is this phone message coming through loud and clear? Is it fuzzy? Are we okay?
And if anybody's having trouble with sound, either let me know through the chat or raise your hand. And so somebody wrote, Cindy Ardans wrote fine. So.
Okay, good. Well, then let's just jump into the next slide, please. We've all gone to the course where they say when you give a talk, you tell people what you're going to tell them and then tell them and then summarize. But there are 5 messages that I'll just headline. One of them is that we consider in California that we've been doing pilots, so-called pilots of the ACO concept, really since the early 90s, and none of these pilots have had the whole thing going, but we have made most of the developmental mistakes in California that are going to be made elsewhere in the country with the ACO concept. And we've also tested a lot of the over-optimistic hypotheses in a lot of different geographic areas and with a lot of structures. So we've been very, very eager to share our experience with the rest of the country. And by participating with the Brookings and Dartmouth Institution, which has a national learning network, we've really learned a lot and shared a lot. And much of what I'm going to be presenting today, I've also shared with that national discussion forum. Yes.
Well, sorry to interrupt. One person said that they are having trouble hearing you. I don't know if there's a way to, if you can speak closer to
I'm pushing the volume button. Is that helping or hurting?
That is helping for me.
Okay, good. Are we better?
It's better for me. I'm not sure if it was better for the person who.
Okay. Well, we'll jump in and keep feeding me these messages because I want to make this good for everybody.
It's better for her. It's better for her.
Second message is that the ACO concept, at least in the partial take that we've been doing in California, does work. It improves both quality and affordability, which are the two sort of national mandates that came out in the reform legislation for a better functioning healthcare system. It works for large populations, not just little tiny pilot places, and it works in a very wide variety of regions, both geographically and in population demographics. And this whole little list of tedious adjectives, I'm going to go through them because they're actually important. The California Medical Group experience, which we believe leads into the ACO concept, crucial element is that they're locally organized. They're not remote large systems. These are locally rooted. They're motivated and led ethically with clinical motivation. That means doctors and nurses are driving decisions rather than a strictly business decision driver. They're technologically sophisticated, and California medical groups really have led the way to using health IT to know better what we're doing, how we're doing, and who needs what. Administratively competent is an important word because if you don't have that, we have individual doctors and individual offices doing things separately, and that's generally speaking chaos. So the administrative competence that's a central function of California groups, that is going to have to be a major part of the national structure. And fiscally responsible. The fact that California medical groups take risk means that they're aware of where their dollars are going, and then they're aware of sources of waste and presumably doing something about it. And I'm not going to suggest that we do that all consistently. We know we have variability. So let's go to the next slide, please. Another message is that part of the ACO obligation is going to be to adopt complex payment methodologies. We know that fee-for-service drives waste and drives inappropriate utilization. Capitation in its pure form has theoretical problems with it, namely that people suspect that that will lead to restriction of care. And we know that different kinds of payment methodologies lead to different sets of incentives. If ACOs are going to succeed, they're going to need to use lots of different ways of paying for services, and we believe that our experience has led us to experiment with that, and we think we know some of the things that work. I mentioned administrative sophistication. It's more than just doing balance sheets and paying people. It's really crucial to have network relationships that work. You have to understand who needs what and respond to those needs at all levels. Care management is an important part of everything that we do, and you can't do that just off the top of your head. It has to be done in an organized way. It has to be paid for, has to be sustainable, and it has to support creative ideas. So we think we've got that. And we now have, thanks to the reform bill that was just passed, the ACO concept embedded in federal law. Next, please. A little bit about my bias. Among medical groups, CAPG is an organization of 150 medical groups. If you add up their HMO and PPO patients that they take care of, it's around 18 million people, so roughly half the folks in the state. It's involved with both governmental payers and private sector and senior care. And I think one of the things about CAPG that has helped us get involved with this is that we really do have a collaborator culture. We know that no one entity of healthcare can change the environment alone. They can only do it working with others, and I think this has really led us to where we are. And of course, the whole concept that we measure what we do and we're accountable for our performance, that also syncs very well with the federal ideas. Next, please. Again, acknowledging my bias from the medical group standpoint, we really believe that community-wide systems of care rather than individual doctor office is where population-based responsible care comes. That it doesn't matter how good any individual doctor is unless that doctor is connected with a system to others, that you can't really influence care for a large number of people. It's also our bias that the medical group provides infrastructure support for superb medical care by delivering things to doctors that they couldn't either afford or learn how to use on their own, and IT support is one example. And we really believe that you can't really have an advanced medical home without elements of support that very few doctors, could provide on their own. And of course, in return, the groups expect people to play as a team instead of as individuals. Another important element that we have to deal with is the whole soap opera caricature that managed care in California and medical groups and health plans are all stingy people that are depriving folks of necessary services and keeping the change. And we know, that caricature never was accurate in a large degree, but it certainly hasn't been present for 10 or 15 years. And we really try to save money by doing the right thing first instead of standing in the way. I think we can go to the next. So where did the ACO come from and how did it get here? These three, these nice little initials, really nobody had seen them, at least widely, until New Year's 2009. This was, we had a new president, healthcare reform was on the agenda, and the ACO popped into public view. And it popped into public view largely because of a lot of very influential and powerfully stated writings, largely from New England, from Dartmouth, from Brookings, the Bostonian Brain Trust published heavily on this, and they struck a chord with most of the people writing reform legislation that this is the way to go. If we have local systems that are accountable, that have novel payment schemes, that this is one way we can deal with the toxicity of fee-for-service payment, and we can also get quality systematically and accelerate it. The Brookings folks had a very strong influence on CMS policy with Mark McClellan and Elliot Fisher leading the way. No surprise given those personalities. So Brookings set up a learning institute that has been active on a weekly or monthly basis around the country, and lots of participation. So the ACO concept got a lot of buy-in early, and of course they recognized California's experience as hopefully offering some guidance. Next. There are basically three things in the ACO that are sort of the three pillars, the three legs of the stool. One that we talked about before is that they're local. We're not talking about something that covers the whole state of California. We realize that we have to have some regional customization, and that there's also accountability to a local populace. But the accountability has to come through in standardized ways. In other words, if there's a performance measure that a group in Iowa and a group in the Inland Empire and a group in Sacramento are using, they should all be the same measures so we can compare performance, learn from the people that are doing good work, and help the people that need help. And payment reform is the third leg. We all know that the systems that we currently have, fee-for-service in particular, are not going to work in the future, and we need to change that. And nobody really knows exactly what the best way to do it will be. So saying payment reform is not saying we know specifically what that's going to be. Next, Karen. The things that the ACOs will likely have to offer in order to do that, number one is a full continuum of care. So that means ambulatory care, it means ancillary services on the outside, it means inpatient care, it means nursing homes, and it means transportation. And between all of those, there are interfaces that need to be synced up. So if someone's coming into the hospital through the emergency room, going out of the hospital to a nursing home and then to home or to home care, all of those transitions of care need to need to be included under the same tent. Otherwise, we have chaos and disconnects, which we're very familiar with now. Second thing is, yes.
There's a question.
Yes.
Steve, I will unmute your line so you can ask your question.
Oh, sorry, I pressed the wrong button.
Oh, okay.
No worries. At least the whole computer didn't turn off, which has happened to me. Second thing of ACO's attributes that we'll likely have is that they have to be big enough to work. In order to have the administrative capabilities to do the complex accounting and payment methods, to create the systems to identify people that are in need, people that are missing services, people that are falling through the cracks, you have to be big enough to have that horsepower. And so when people talk about ACOs, I think we're looking pretty much at some of the same parameters that are believed to be true for medical groups, and that is you need to have probably 30,000 covered lives or more to be able to support the administration that you need to do this well. And there's a lot of learning that's in our future about what are optimum sizes. It may be that some of the smaller ones will need to merge with others, need to create new alliances. We just don't know. And finally, the law only covers Medicare and Medicaid. The law does not affect ACOs, does not require people in commercial coverage to participate in ACOs. However, we do anticipate that commercial health plans will want to piggyback on the good things that ACOs do and try to shape some of the other things in a way that's sustainable for their business. But right now, at least from the legal standpoint, it's only governmental payers. Okay, next. What did the Reform Act say? The Reform Act is over 2,000 pages long, and the section on ACOs is not the thickest of them, but HHS is going to be designing a method to share savings if an ACO beats actuarial predictions and there's money left over. That should be plowed back into incentives. The actual systems of how that will work remain to be designed, but a lot of people have ideas. Also, if you have people sharing dollars and they're competing with each other or competing in the same environment, there are immediate federal trade concerns about whether that's legal or not, and the government is going to have to do a lot of work there. The concept is fairly wide-ranging as well. We don't have people excluded. It's a pretty much open entry to the arena as long as you can fulfill some of those criteria. And there'll be a lot of firming up of those concepts about who's got enough to offer to become an ACO. Obviously, mature, large organizations that are already doing some of these things will be quick out of the blocks, and others will have a fairly long developmental ramp-up. And some states, I've talked to people all over the country, some states like New Hampshire, Vermont that have really good doctors and high outcomes and enlightened healthcare systems in some ways don't know how to do some of the things that ACOs are going to need to do. So everyone's going to have to be looking at a checklist. Also in the law, this was new, the Medicaid law does allow pediatric-only groups to become ACOs, and that'll be interesting for a few areas in California like San Diego. And, when does this all start? CMS is charged with having this up and ready to go by January 2012, which is just a year and a half from now. Pretty ambitious. Next slide. Most of the people talking about ACOs nationally, kind of look at them as small, medium, and large in terms of sophistication. The first tier will likely to be, simple gain sharing, which is an ACO will have responsibility for a certain population. There will be cost projections for how much that care should cost. If the organization beats that, it gets to share some of the savings with the people inside. That doesn't require a whole lot of care management infrastructure yet, although it's expected that will be developed. And it also doesn't require the same kind of financial sophistication. Sort of the step above that would be groups that are capable of handling either bundled payments or partial capitation and sharing that money internally. And those groups would probably have an opportunity for a greater share of the savings. And Tier 3, where we think a lot of California groups are now, would be groups that have a lot of that infrastructure already in place and are willing to take risk. And the more risk they take, probably the greater share of savings they may be able to achieve. Again, all of these are concepts that have not yet been put on paper, and that's going to be a daunting task for CMS to do in a year and a half. Next, please. So you're reading between the lines after what I just said. What does that mean? There are some awkwardnesses here because hospitals are going to have to get back into, as I say, the collaboration business with other healthcare institutions in the community with whom their ties may not be strong. We have everything in California from fully vertically integrated hospital and medical group systems like Kaiser Permanente, like the Sharp system. We can have others. We have some that have medical groups and hospitals in the same organization. Sutter's an example of that. And we have some medical groups that operate completely independently from the hospitals, and all of them have sort of separate histories. But an ACO will have to have both ambulatory and inpatient care in some way, sharing responsibility, sharing revenue, and learning how to share leadership. And that's not going to be easy. What I mentioned, the NATO analogy is in NATO, ostensibly there are equal partners, but Belgium and the United States have a very different kind of swagger in that organization. And whether the hospital wants to be France or Germany or the United States or Belgium, that'll remain to be seen. But there's going to be a lot of relationship building that needs to happen. Capitation is definitely coming back. California is the only state where capitation is a widespread payment methodology, but Massachusetts knows that they need to get back into that. And prepayment and working on a budget turns out to be effective for cost control, and we'll be seeing capitation. It'll probably have another name. It'll be prospective payments or bundled payments. They won't want to call it capitation, but it will be capitation. Another thing that is coming that will be a challenge there is that doctors who are fiercely independent and who don't want to be part of a system, they're here now. They're a minority, a slender minority, but they're quite vocal. And what will the role be for a practitioner or a hospital that doesn't want to be part of it? We don't know the answer to that, and that's going to be tense. And anytime there are dollars being divided up by anybody, there's tension. So life is not going to be simple for people building ACOs. Next, please. Putting a sort of a distinctly California twist on some of those concerns, yes, we should be ahead of the rest because we've had 20 years to develop systems that have a lot of the attributes that ACOs theoretically will have. The hospital buy-in is one. Hospitals and medical groups, as you know, tended to drift apart when risk sharing petered out 10 years ago, and they're going to need to get back into that. Public and private sector overlap. We've got governmental payers and private payers. They're going to be using some of the same systems. How do they apportion overhead? What happens to the cost shifting that currently happens? We don't know the answer to that. Rural settings where there's not a large concentration of medical services and where there are no organized systems already, how are you going to create an integrating structure in those areas? Again, nobody knows the answer to that yet. And crucially, which we'll talk about and spend much of the second half of this talk, is what does that say about the primary care workforce problem that we know is bearing down on us? Again, keeping in mind that ACOs are being created first and foremost to curtail the cost inflation in healthcare. 17% of our gross domestic products going into healthcare. That will cripple the country. The ACOs are being created not so much for improvement of quality, that's got to be part of it, but it's mostly being created as a national security measure, frankly, to put a damper on these costs. So anything that we talk about, all of the parties that are looking out for self-interest, they've got to remember that the outcome from this needs to be attenuated costs. Next, please. Okay, private public sector issues, community health centers, federally qualified health centers, how do they fit in? You know, I've obviously had the experience and the bias talking about organized medical groups. Well, how about the community health centers? The federal law doesn't really, you know, separate that out and talk about that. This is something we're all going to need to work out. But in general, and this has been you know, part of my experience working with Medi-Cal managed care, most of these organizations do an essential community service, and some of them do a spectacular job, but very few of them have a full spectrum of services. There are a lot that you know, very, very rarely have inpatient coverage. Some don't even have night call. And the administrative structures that they had are designed for their needs, but they are generally not designed for handling a whole array of complex payment schemes. And relationships with non-clinic providers are, you know, are a challenge, especially with certain hard-to-find specialists. So it's not likely, I don't think, that an FQHC or a community health center is going to become a freestanding ACO. They'll probably be included as an integral part of one. And I think as we look at the county organized health system model, we've got a model that works where all of these parties cooperate in a local region to do better things for society. I think we will have lots of experiments that come. Next. Okay, getting back to the primary care question, you know, are ACOs going to be a good thing or a bad thing for PCPs? Well, nobody really knows. Theoretically, it should be better now because we should have the opportunity for primary care physicians to get better infrastructure support, better information, better help navigating complex systems for their patients, better help setting up some of their own systems, better information for self-assessment and improvement. Theoretically, this should be good for primary care. Certainly, if an ACO has a way to pay people for services that are not reimbursable currently. I mean, you know, as a pediatrician, I couldn't get paid for spending 2 hours on the phone trying to coordinate care with a doctor at Stanford for one of my patients. Well, that's valuable time, but I got zero back from it. But if there's a different way of looking at rewards, maybe that can be different. We expect it to be. I think another part of that is that doctors are no longer going to be able to get away as saying, well, this is the way I do it, so there. It's going to be very hard for doctors to be isolated islands. They're going to have to be part of an archipelago that's connected. And I think most doctors that have that experience realize that enables them to be better doctors and provide better outcomes for their patients. Next slide. Well, you know, looking at it as a former PCP and someone whose basic concept of healthcare depends on a vital PCP workforce, the real question that I would put out is that, you know, does participating in the ACO, and I could say the medical group the same way, does that enable you to do the things that you went into medicine to do in the first place? And you know, and does it allow you to have a lifestyle that's enjoyable and an income that, you know, that allows you comfort? If the answer to that is yes, then I think we're in good shape. I think the answer is probably going to be yes, but it's not going to happen just because someone creates an ACO. The voice of the primary care physicians is going to need to be very, very loud and strong throughout. Some of that voice may be skeptical, and you know, I know organized medicine is looking at this with great caution, but the important thing is you have to be part of the conversation, and that would be true for trade organizations like family practice and pediatric organizations. It's going to be true for local consortia as well. Next. Okay, well, I speak fluent Spanish, but my Russian is bad, and I call this a Petrushka doll concept, but it's actually a Matrushka doll concept. So forgive me for exposing my my flawed diversity. But the Matryoshka dolls are the little Russian nesting dolls where you've got one inside the other, inside the other, inside the other. And I'm just going to sort of put this out as a model because it's the way I think of things. At the very core of good health care, you've got a high-functioning medical home. You've got an organization or physicians that are committed to delivering high-quality care, that have the tools to do so, that are measuring what they do, and are constantly learning and expanding their skills. Well, you have to have that. There's no overarching system that can replace what a really good doctor can do on the street. So that's our foundation, medical homes that are, not just content to fulfill a checklist, but really doing a lot of things very well. Inside that, or I say they fit inside, my vision is the medical group that provides them with a lot of the support systems that they either can't afford to provide on their own or don't know how. And certainly IT systems can be part of that. But there's also a lot of care management systems, help tracking down people using registries, folks that are following outside guidelines or facing medical dangers. You need help identifying that and finding them and offering them better choices. And I see the ACO concept as the doll that surrounds that. The ACO, if we have a medical home inside a medical neighborhood, the ACO is sort of the city. It's got fire and police protection, got roads, got education, and it has a much broader population to whom it's responsible. So people say, well, which is going to be more important, the medical home or the ACO or whatever? I think the reality is that we need all of these to function in a coordinated way. Next, please, Karen. Elaborating a little bit more on the medical home and the medical neighborhood concept, we talked about IT tools. This has been published in the family practice journals that very few small practices, even 10 or 15 docs, can come up with the IT sophistication that you really need to provide the services that are potentially available. The ability to measure yourself, give yourself feedback, and generate improvement responses to that is very, very rare and a small nugget. I think you need community-wide approaches to that, and medical groups offer that. The connectivity with specialists, as well as the obligation for specialists to respond in a meaningful way and to have meaningful bilateral communication that benefits patient and care coordination. Very hard for individual doctors to create systems like that on their own, but a medical group does it routinely. The whole question of how do you pay for people? Fee-for-service payment, you get paid for doing things over and over again. You don't really get paid for having better outcomes. We know that we've got to fix that in the future. Medical groups have some experience with that, but that needs to mature. Another thing that's important is in a medical neighborhood, you can create incentives to welcome and take care of the really complicated, difficult patients. I mean, these are the patients that really need systematic care. An ACO can structure it so that doctors taking care of those folks get paid commensurately with the challenges that they face. We don't have that very well yet, but we can. Next slide. Aside from paying attention to how much it costs, there are other things that a medical group, I should say the medical neighborhood, can provide. And navigation systems, case management people that are able to get people to the right place. An ability to hear the public voice and respond to demands for convenience and access. A lot of individual doctors don't have their hearing set up very well for that. The ability to respond to different cultures and different languages. Very hard for an individual doctor's office to do all of those things, but a medical group has the horsepower to do so and then share it. Next, please. And I'm accelerating a little bit because we want to leave about 20 minutes for conversation. Well, what will the ACOs have to do in primary care? And to make primary care an appealing professional destination, and what do they need to do to start? And, one is more money. I mean, the English primary care docs are pretty content. They make more than primary care docs do here, and they probably enjoy greater respect. The fact that primary care physicians are caring now about personal growth and health and family above and beyond their sort of medical keyhole, that needs to be part of a system trait. And when we talk about responsibilities, that has to be more than just filling out a whole lot of paper, which is the way a lot of docs feel that their lives have gone down the tubes. So an ACO that functions well is going to have to be able to help doctors spend their time doing the things that are important and get rid of the junk that doesn't really add value. Next. Okay. The next couple of slides talk about a little more detail about the infrastructure that we have with California medical groups and how I think that relates to the ACO. I think in the interest of time, Karen, I may shift over these. All of these slides are available, and go down to the last couple of slides, and then I can go back to these if there are specific questions. So can we go down to the slide that talks about, yeah, keep going. Yeah, stop there. As I finish up talking, we talked about some of the things that that are facing us as challenges. There's a whole lot of things that we haven't fixed now before the ACO concept was built, and that medical groups have not solved. And I'm not going to suggest that simply passing a law is going to change that. Primary care workforce shrinkage, we've talked about that, and everyone knows that that's a looming threat. Crucial issue is that we've got all of a sudden under the ACO concept, all of these different parties sort of obliged to start working together and trusting each other. And they don't trust each other now. Government, health insurance plans, they're at each other's throats. Medical groups and hospitals bicker, medical associations bicker with CAPG, employers and purchasers are unhappy with the value of what they get. Advocacy groups are not generally happy with what they're receiving. So the idea that they're all, between now and January 2012, going to sit down, find common ground, and work this out and design perfectly functioning systems is probably a little naive. On the other hand, there's only one way to do this, which is person to person, and we might as well get started now. Some of the misaligned incentives that have ballooned our costs in America, fee-for-service, payment for things that don't work, payment for things that could have been avoided, that's not going to magically go away. These engines are not going to just all of a sudden stop. They're going to hum along for a while, and it's going to take a lot of work. We know that in California there are areas with dramatically richer human resources, lots more money, lots more healthcare facilities of every respect. That's not going to change all of a sudden, and we're still going to have some disparities in the ability of local organizations to do things. One of those disparities has to do with money to build systems. You can't build sophisticated systems with just goodwill. It takes money, and so where is that startup money coming from? And then the other thing, of course, is that if we want to retard the growth in costs, that means some of the people that are making money and very happy with that now are going to be less happy later, and they're not just going to roll over and surrender. They're going to fight back and protect their self-interest, and some of those fights are going to be nasty. Next.
Oh, Wells, we have a question from
Yes.
Nancy Oswald from the Redwood Community Health Coalition, and she asked a couple questions. She asked, could you comment on the fact that the new federal regional extension center funding is available for implementing EHRs in small practices that have less than 10 providers?
Yeah.
And then, well, you can answer that, and then I'll ask you the question.
Sure. I think putting an EHR in a small office is fine. I just don't think it does any good at all for population care unless that's synced up with regional systems so that you're aware of what's going on in a population. I know that sounds a little harsh, but I can put a Ferrari in my garage, and that does not make me a race car driver. It just makes me the owner of a Ferrari. And I think unless we sync up health IT with population-based systems to use that in a way that not only achieves better quality, but also achieves affordability, that it's sort of a sidelight issue. And there's a huge amount of money being spent buying expensive equipment and putting in places where people do not have the know-how to actually use it in a way that benefits the whole community. So I think it's a step forward, but it's not nearly enough. It has to be synced up with the system.
And the second question is, have you heard that this year there is an increase in primary care residents? And do you think that this could be a trend?
Well, the Giants won 6 out of the first 7 games of the season, and that was very encouraging. But then they've lost a bunch. I think before you can call something a trend, you need more than 2 points on a line. I do think that's it's hopeful. Whether those docs stay in bona fide primary care or whether they drift onto concierge practices or they go into Botox or decide to spend an extra year and do a fellowship in some subspecialty, that all remains to be seen. I don't think any of that is going to change until primary care income gets better, respect gets better, and the nature of the work improves so that it challenges your intelligence and your reasons for going into healthcare to start with. And if we can do that, then people will come, because they certainly come in Great Britain. It's a very prideful destination for a physician in training in Great Britain. It's just not that way here yet.
And for those who didn't hear the question, it was about that this year there was an increase in primary care residents, and does Dr. Shoemaker think that this could be a trend? And then there's another question, but I think, Wells, that maybe because you're very close to the end, maybe we should go to the next. I think
sure. We are close, and people like Nancy ask questions that first of all expose gaps in your knowledge, but they could also trigger an awful lot of great conversation. Okay, last couple of slides really is that right now, I think we are sitting in an opportunity that I've waited more than 40 years in my career for, and that I think we're facing. Thanks to the Reform Act and thanks to some of these economic pressures, we have a mandate to do things that are creative, and we've got the ability to communicate in a hurry and share. And I think this is going to be the most exciting few years in healthcare that any of us have ever lived through, and what an opportunity. Just because it's going to be hard shouldn't be any reason to be looking down at your feet. We also know that a lot of disruption is going to occur, and some of the things that we do are not going to work very well, and we have to learn from that and share it quickly. My analogy there is that we plow the field so we can plant crops. Some weeds are going to sprout too. We just have to be willing to go and pull them out, and that's just going to take a lot of work. The need for diplomacy at all levels is going to be very high. We're talking about relationship building. We're talking about healing some scars, dealing with some deep resentments. Society is depending upon us to have the maturity to do that. And so instead of looking at it in the strict what's in it for me, I'm trying to think, 5 years from now, does our work add up to something that makes the United States a safer, better place to get health care? And, I think that chance is in front of us. I think it's going to be really, really hard. And, but the country's given us the chance to do it. If we don't, then we know we know who failed. So I guess that leads to my next slide, which is, yeah, it's hard and it's heavy, but it can be done by intelligent women. Okay, and then I think that really just leads us to questions. And the last slide, which we won't, I guess you can leave that up now, is contact information. So that leaves us some Q&A time, and I did rush through some of the details on some of the structural elements in the ACO that are under the hood. And Karen, I understand that not only the slide deck will be available on the website, but recordings of the Q&A will also be available. Is that correct?
Yes,
okay.
The whole of your presentation and the questions and responses. And so we have a second question, or a third question, and that is, what do you think will be the role of the local regional health plans in supporting ACOs? And do you see community clinic consortia acting as ACOs?
I do not see a community clinic consortium acting as an ACO unless it has a hospital or hospitals and nursing homes and a specialist network that are involved in accountability for utilization and quality, and unless it has a way to pay for those services where the payment system is aligned to stimulate affordability. Again, I don't think community consortia community clinic consortia at this point have that under their hoods. I see them as an integral part of a larger system. Would that keep someone from developing such a thing? No, not at all. I would hope that there will be geographic experiments, but I don't see that infrastructure coming into play in the next year and a half. I think it'll probably take a decade.
And then the other question was, what do you see as the role of the local or regional health plans in supporting the ACOs?
Well, it's interesting. California has a number of models for local health plans. There are some commercial ones, like CIN, and there are lots of public sector health plans. The community organized health systems take care of a full spectrum of aid codes. They've got a formal community board that guides them. They're fiscally accountable. They live in a budget, and they're accountable for quality. So, we have 5 county organized health systems in California, and just about all of them take care of more than one county now. I think San Mateo and Orange County are still one county organizations. But we definitely have models where the health plan and the provider organizations and the hospitals all have a contractual linkage, and I think this is a great model. How about a statewide health plan, though? Say a Health Net or an Anthem or United Healthcare. They're not local. They obviously know a lot about different local situations, but they have a much bigger tent. How are they going to interact with ACOs? Well, I think that's that blackboard doesn't have a lot of chalk on it yet. First of all, commercial health plans are not mandated to participate in this. It's really just governmental payers. But if the ACOs do work and they achieve higher quality and better affordability for governmental payers, I'm very certain that the commercial payers will want to be part of that, and they have a lot of expertise that could help make that work. So I think a lot of, how does it work for me question is probably very active in different health plans, not just in California, but around the country. How do we piggyback on this so that it works well for us, that preserves choice for people that want to buy our products, and how can we make sure that that this doesn't just become a big money suck that doesn't work and leaves us with a mess. So, yeah.
Oh, so we have a couple more questions. First from Kathy. I'll unmute your line, and then Chris Camisa from Partnership Health Plan also has a question. His question will be after Kathy's.
Hi, Kathy.
Hi. I was just wondering if there are any communities that have already stuck their toe in the water and might have some best practices that in terms of ACOs. I mean, Humboldt or others that we might learn from, early adopters.
Well, I think there are, it's our prejudice that we have lots of systems in California that have pretty much tested the whole concept and it works. And these tend to be larger systems that have, hospitals already involved. But, Kaiser Permanente is certainly one example. You look at the SHARP system, you look at larger integrated groups that have formal binding relationships with hospitals where those groups are taking full risk. Healthcare Partners would be one example. There are quite a few examples elsewhere of somewhat smaller organizations. So it's our sense that, we have almost all of the pieces together in some places and most of the pieces together in others. the big exception being the northeast quadrant of the state, where it's very sparse population and there are no real integrating medical structures other than the medical society, and the medical society has generally not been involved in issues of affordability or quality.
Okay.
So rephrasing that, so we think we are well down the pike towards having this, but we're going to have to create the relationships with nursing homes and hospitals in a lot of different settings, and deal with the tough negotiations to make those mutually beneficial. And at the same time, if we are cutting costs to society, who's going to give up what, and what do they get in return? I don't have a cutesy answer to that. I just think it's going to take a lot of work, and I think there are going to be a lot of local experiments that will inform the general dialogue.
Thank you.
Thanks, Kathy. Dr. Camisa?
Yeah, Wells, really excellent presentation. I really like the way that you see the big picture. But my question is more about so what's going to happen in 2012? Is the federal government going to put money on the table for applicants to apply and have specific criteria? And will this be, like if a health plan were to do it, would it be additional dollars that we have the potential to get for results or for upfront implementation of a ACO? I just don't kind of understand how the mechanics are going to work.
Yeah, the CMS bureaucracy for ACOs needs to be in place and functioning by January 2012. What they will be doing starting then and going on for at least 4 or 5 years is testing pilots. So they'll be testing pilots in North Dakota, and they'll be testing pilots in Temecula, and they'll be testing pilots in lots of places. Some of those pilots will be for sort of new entry, first-tier ACOs, but some of those pilots will be taking, mature organizations that already have a lot of that infrastructure and, seeing how that runs. So I think we're going to have pilots being tested at all levels of sophistication, and there will be money for that, because an obligation for participating in a pilot is you have to report your results and teach other people. As far as organizations that have most of the pieces there and want to get started, want to start taking risk and being accountable to the public for their performance, there are a lot of California organizations that are ready to start tomorrow with that. So I think there's not going to be one single answer. There will be federal money. The money for testing is one thing. The money later on for how does a group make money with this so that it has money to design incentives? The answer to that is that money is not going to be new money that comes from the government or comes from taxpayers. That money is going to be money that's currently being wasted, that's now being funneled into processes that are productive and responsive. Most of us figure that there's anywhere from 20 to 35% waste in the healthcare system now, and that if we were able to, to capture even a small portion of that, we could build infrastructure and have systems that serve people better. So, and again, Chris, the actual CMS rules about what this is going to look like haven't been written. The law's a month old. CMS is, was given a wheelbarrow full of commands and tasks. They're not staffed up for it yet. They're probably starting to get lots of pressure from stakeholders with self-interest, and so the ability to really answer your question with technical accuracy just simply doesn't exist now, but we expect that information to keep flowing steadily. And I know at the CAPG conference coming up in a couple of weeks, Elliot Fisher and Mark McClellan will be talking about that. So I think it's changing weekly. You have to stay tuned.
Thanks. That's very helpful, Wells.
We have a couple more questions. One is, who will oversee the pilots? I think that the pilots that you referred to when answering Dr. Camisa's question. And then the second question is, from when from where and when will interested entities receive the criteria so that they can start working with partners to form a full ACO?
I think, where and when and what are the criteria of, what I've talked about is sort of general attributes here. There's plenty of work to do to get started on building those relationships now. As far as having a formal checklist that says, you qualify at X, Y, or Z level, that doesn't exist yet. Those are sort of being written. But what I think does exist is the fact that the country is moving in this direction. It's part of a federal law, and we know we've got to do some things that we currently are not doing well enough, and that means synchronizing inpatient and outpatient care. It means using evidence-based criteria to decide what we do for whom, and doing that in a way where the public can look through the windows and see exactly what's going on inside the box. If we start working in those directions, as the specifics start trickling out from CMS, we won't have wasted our time by getting started now. What we'll do is we'll probably, it's like driving from Los Angeles to San Francisco. You don't really need to know which turnoff you take to get to Sunnyvale when you're just leaving. You start driving north, and then you pay attention to that and alter your course when you get closer to it. I know that sounds like a lame answer. I guess what I really want to relay is that there are so many things clearly that we can start doing now that are going to put us closer, and when we get the particulars, we will be better able to handle those if we start our work now.
And the other question was, who oversees the pilots that will be part of it?
Yeah, pilots will be overseen by CMS. That will be it will be with Medicare and Medicaid dollars, and there will be, you answer to the person that gives you the money. So if the money comes from CMS, then you will be overseen and report to CMS. When I had my AHRQ grant, I knew exactly who I had to report to, and I don't think there will be any lack of clarity about that if anybody's actually getting money.
So we have time for one more question. I don't know if anybody, you can use the raise hand function or type it into the chat.
Karen, I think people are not raising their hand because I didn't give specific enough answers, and I apologize if that's the case. I do think in the slides that I skipped over, the ones, there are 4 or 5 slides called Under the Hood, which go into more detail about some of the functions that medical groups currently have that ACOs are going to have. A lot of those elements may be useful for folks to check into later, and I'd be overjoyed to continue this conversation with anyone by email or by phone later on too.
Okay, well, I guess if there aren't further questions, I'd like to thank everybody for joining, and I'd like to thank you, Wells, for an excellent presentation. We will send the recording and the slides later today. If you have any questions, again, feel free to contact Dr. Shoemaker or me with additional questions. And I just wanted to let everyone know that the next CIN webinar will be on Wednesday, May 26th from 12:30 to 1:30 p.m. And it will be about the ambulatory intensive caring unit concept with a focus on Boeing's recent pilot program that improved care and reduced costs for patients with multiple conditions. And we'll send that information in the next couple days. So thank you again, everyone, and have a great rest of the afternoon. Thank you, Wells.
Thank you, Karen. And I hope we were open enough to questions to make it worthwhile.
Oh yeah, it was great. Thank you.
Yeah, and if you get later follow-up